everyone for joining us this evening again. It is the 6th in our webinar series on the CamAPS FX Webinars. Please use the chat function to ask questions during the webinar. We will be recording the session and it will be uploaded to be watched later on the CamAPS online training platform if you want to watch it back. Please keep your cameras off and on mute. So thank you. Let's get going. So this is a session on pregnancy. The next one we will have is on infants, toddlers and young children, then on adults and young adults, and the next webinar is on managing physical activity, high fats and other sort of meals and other life events. So do book in for those. The team tonight is, as usual, Charlotte and Sarah will be leading the session, but we're very excited to have Helen Murphy with us today. As you may know, she's an expert on pregnancy and diabetes and will be sharing some pearls of wisdom with us. Thank you very much. So I'm going to hand over to Helen to start the session. Thank you, Helen.
So yes, welcome and thank you everyone. So we're going to have a run through of really using the CamAPS system during pregnancy in women with type 1 diabetes. So we'll talk about a little bit of an overview of diabetes in pregnancy, specifically the glucose targets for women using closed loop systems. We'll go into a little bit more detail about the CamAPS system and how it works, about focusing really on starting and getting going in pregnancy, using the more advanced functions, the boost and ease off, getting the basics right. So actually really focusing on bolusing, accuracy of carb counting, times of prandial bolus insulin. We'll share some of our insights in the approach that we take to reviewing the data. And then we'll talk a little bit at the end about using closed loop during hospital admissions for steroids, during labour and delivery, during caesarean sections, and the immediate postnatal period. Now, I think everyone listening in is probably well aware that most women with diabetes will have healthy, normal babies. But of course, the rate of obstetric complications is much higher for women with type 1 diabetes than the background maternity population. And specifically, about 1 in 2 babies are born large for gestational age, and about 4 in 10 are delivered before 37 weeks. And many of those large or preterm babies will need neonatal intensive care unit admissions. Now, of course, the aim and what we want and what women with type 1 diabetes want is to reach these tight pregnancy glucose targets before pregnancy if possible, but as soon as possible once pregnancy is confirmed. And we know that the earlier that women reach the pregnancy glucose targets, the better the outcomes, both for the mothers and for the babies. So now we're going to just talk a little bit about the glucose targets in pregnancy. And I think everyone will now be familiar with the concept of using time in range. So in pregnancy specifically, we're aiming for 70% of the glucose levels in the pregnancy target range of 3.5 to 7.8, no more than 25% above 7.8, no more than 4% below, no more than 1% in the extreme lower below 3. Or keeping our eye also on mean glucose, and we'll come back to that later. So a little bit about the system and how it works, and then I'm handing over to Charlotte.
Thanks, Helen. So a lot of these things we've covered in our previous webinars. So if there's any bits that you feel you want to look at in more detail, then by all means go back to those, or also we've got some training modules as well. So there's a few closed loop systems out and about there, although this is the only system that's licensed for use in pregnancy. So just an overview about how this system works. So the way it modulates insulin delivery is it sets the pump basal rates to 0 and then adjusts a new extended bolus every 8 to 12 minutes in a glucose responsive fashion. What this does mean is that on the pump itself, it flashes up as no delivery. And you can see that on the image here, but you can see just above that, you'll see the extended bolus that's being given. So other causes for no delivery that may be of concern, so an occlusion or a low reservoir, will result in the pump alarming or vibrating. Whereas when closed loop or auto mode's in operation, it will flash no delivery, but it won't alert or vibrate. And of course, this is a hybrid closed loop system, so it still requires insulin boluses to cover carbohydrates. It's important to know what's required when you're setting up the CamAPS FX system. So the inputs required for the algorithm, when you start, it just requires the body weight and the total daily insulin dose. And then what it does is the algorithm calculates the insulin sensitivity and active insulin time, and it's constantly learning and adjusting these. So the longer somebody uses the system, the better it gets at sort of adjusting to individual personal needs, and that's the adaptability side to it. In terms of ongoing inputs, it obviously requires real-time continuous glucose monitoring data from the glucose sensor, and input for the carbohydrate and mealtime insulin boluses need to be entered manually. In terms of which settings can be optimized to improve outcomes and to get that sort of time in range targets that Helen was talking about. So the insulin to carbohydrate ratio is really important in getting that accurate and adjusting it throughout the pregnancy, but also adjusting the glucose target. So the system is, the default target is 5.8, and we'll talk a little bit more about that and making that sort of specific to pregnancy, because obviously that target's not necessarily appropriate in pregnancy. Things that won't affect closed loop operation, and therefore there's not much point adjusting them to try and optimize closed loop sort of outcomes, are the active insulin time, the insulin sensitivity, and the pre-programmed basal rates. And that's because the closed loop algorithm is doing those bits for you and adjusting them already. They are important if auto mode isn't available, perhaps during sensor warm-up periods or things like that. So it's important that they're accurate, but they're not going to particularly change the outcomes that you're seeing with closed loop use. So we're going to look now a bit more specifically, and I'll hand you over to Sarah about starting sort of the CamAPS system in pregnancy specifically.
Thanks, Charlotte. So we have done previous webinar, webinar number 2, if you want to have a look, which goes through step by step of how you link all the system and set the app up initially. But the things that are specific to pregnancy are, one of them is the personal glucose target. So as Charlotte said, the algorithm defaults to a target of 5.8, but you can personalize this, and you can set it at different levels for different times of day and night. So what we suggest is in the first trimester, we start with 5.5 when we're just being kind of careful with kind of the earlier sort of hypo risks. And then in the second trimester, dropping it down to 4.5 to 5. And also kind of looking perhaps to have a slightly lower target overnight than during the day. Maybe 5 might feel comfortable during the day, but you could run kind of, I don't know, 10 p.m. through to waking up at 4.5 when there's less variability, to run a bit tighter overnight. That can also help get things in target pre-bed if things have been slightly higher post-evening meal. We're aiming for that time in range of 70% between 3.5 and 7.8, as Helen showed with the target slide. But one of the things that we've found really useful in this group is focusing on the mean glucose as well, and aiming for the mean glucose when you're looking at that data separately between 6 and 6.5. Helen, did you want to say anything else about that?
Yeah, just that's so important, because it's really, of course, the range of between 3.5 and 7.8 is quite wide. So you can have someone sitting, you know, with 70% time in range, but they might still have a mean glucose of 7, which is a bit too high for pregnancy. So yes, looking at both of those things really side by side, time in range, time above range, and mean glucose, and pushing for that mean glucose of 6, pretty much, you know, from as early in pregnancy as possible.
So you might want to consider adjusting the targets and especially lowering them if the glucose variability is low, like I say, overnight, aiming for the slightly lower level of 4.5. If someone's kind of having a run of episodes of hypoglycemia, particularly early on, it's worth just raising the target slightly, but only slightly, kind of to 5.8 is fine, and not leaving it there for sort of weeks on end, just for a few days. To kind of while things flatten out a little bit, and you kind of get control back, and then you can drop it back down again. So that can be useful.
And Sarah, so when I'm looking at, when we say low glucose variability, we're thinking of standard deviation below 2 and a CV below 33%, then you can feel much more confident, yes, to bring that target down a little bit.
Yeah, great. So other things that you might need to adjust thinking about pregnancy is the basal rate. So as Charlotte said, the pump basal rates aren't used when the system is in auto mode, but what they are important for is the safety default. So if the pump reverts to open loop, then the system will revert back to those preset basal rates. So it's important as the total daily dose increases as pregnancy goes on, that those basal rates are adjusted and upped on a regular basis, kind of 4 weekly. You might also, if weight has changed significantly, you might also want to adjust the weight in the settings menu of the app. And it's also worth remembering to increase the max bolus and the daily max in the doctor's mode settings. So those sort of safety parameters as the total daily dose increases. Otherwise, you run the risk of maxing out and the pump, and you get an alarm saying max bolus reached or daily max reached, and then the pump reverts to the system reverts to open loop again. And actually, I think it can even stop delivering insulin completely if you've completely maxed out. So that's really important. I'm not going to go through this in detail, but we often get asked, how do you change those, adjust those settings? So as Candice said, this session's recorded, so this slide will be available to you for you to have a look back if you can't remember where to change either the basals, or I think on the next slide is changing the settings in the doctor's mode. It's all on that side for you, and you can always have a look back as a point of reference.
So just thinking about some of the functions that are available with this system. So there's two sort of modes that can be used to sort of adjust how the algorithm's working. These are called ease off and boost. So just a little bit of detail about what they do. So the ease off setting it substantially reduces the insulin delivery, and it temporarily will raise the glucose target, and it also stops insulin delivery if the glucose goes sort of less than 7. So it's working in sort of several different ways to ultimately make the algorithm a bit less aggressive. It can be useful, particularly before, during and after exercise or activity. Following a period of hypoglycemia, the algorithm in itself will back off. It's glucose responsive, but it can be helpful if you've had a nasty hypo at the beginning of the day and really want to make sure that you're avoiding additional hypos later on that day or overnight. And sometimes where people are a bit more insulin sensitive during hot weather, it can be useful just to sort of those initial adjustments and to prevent hypos. It can be set either sort of immediately or in advance. So if somebody's sort of doing something early in the morning and doesn't want to get up and start it before activity, they can put it on to come on at sort of 4 in the morning. So it's become the algorithm's a bit less aggressive in advance of that. What it won't be able to do, however, is to mitigate inaccurate insulin boluses. So you can see here, this is a Diasend sort of screen grab. And on the top panel, you've got the continuous glucose monitoring data. You've got Boost, which is shown in Diasend as red hashed lines, and the yellow is ease off. And you can see that sort of 1 o'clock, a 35 unit bolus is given, and somebody's popped ease off on at the point that actually they're hypo. So ease off isn't going to be able to take out insulin that's already been delivered. Yeah, so it's just worth knowing it's a helpful function, but it's got limitations as well. Once the insulin's in, the insulin's in. The sort of opposite function to ease off, and I think this is particularly useful in pregnancy, is boost. So this sort of makes the algorithm more aggressive. It will increase the basal insulin delivery by around about 35%. It's a bit more complicated than that. There's a few things going on behind the scenes. But what's nice about boost is that once the glucose target is reached, it won't continue to push. It will just aggressively treat deviations from the target glucose. So it's sort of like a smart temporary basal. So times when it can be really useful to help manage some postprandial hyperglycemia or sort of high fat meals, those typical kind of pizza meals, hopefully not too many of them, but also low grade illness, which wouldn't require sick day rules. So where ketones are low or not present. And again, with the boost, you can set it to come on immediately or as a planned boost in advance. And both of these sort of functions can be put on for up to 12 or 24 hours.
And Charlotte, I'd say it's almost ubiquitous. Certainly after about 12 to 14 weeks, most women need to be using Boost, especially after the evening meal, it seems. And often they think they'll just put it on for an hour or two. So it's really important to reiterate that message. You can leave it on for longer, stick it on for like 2 to 4 hours, knowing that it will safely turn itself off.
Brilliant. And if you need any convincing for that, so this is a screen grab which just shows somebody who popped Boost on at sort of midnight time, and actually you can see around about 6 o'clock in the morning their target was actually 5.8 for this, and it sort of backed off at that point once it reaches target. So yeah, it's a relatively safe way. It's worth just keeping an eye on what happens initially with it, but it's pretty safe to keep on overnight and much better than what we're used to with standard pump therapy and temporary basal rates where it's not glucose responsive. So I'm just going to hand you back now to Sarah, who's going to talk through some more of getting the basics right.
Yeah, so one of the really crucial things is the only other thing other than the personal glucose target that you can actually adjust is making sure that your carb ratios are right, but also that carb counting is accurate. The amount and type of carbohydrate is so important, encouraging low glycemic index, thinking about accuracy. If you ask someone how good is your carb counting, they'll always say it's good, and actually often it's really not. It's just worth asking people to kind of revisit, get the scales out, just weigh some things again, and just check that it's as kind of accurate as they kind of feel that they're being. Auto mode will correct some post-meal hyperglycemia, but if you want to keep in those really tight targets of not going above 7.8, then the accurate carb counting, the quality and quantity of the carbohydrate is super important. Boost can help, and specifically with those high fat, high protein meals as well, that can be useful. But this was a quote from Helen, I think, that diabetes in pregnancy, 90% diet, 10% insulin. And if you think, sorry, carry on.
I think that's absolutely, because we know the system does a brilliant job overnight. But of course, if women have a really high and particularly a late evening meal that's high in carbohydrates, the glucose from that is still going to be appearing in the bloodstream up to 6 to 8 hours later. So really, from midnight through to 4 a.m., you're still seeing the appearance of glucose from dinner. So it's so important, especially to get the evening meal, for the carbs to be, not too high, and for that meal to be not too late. Otherwise, just the effects of it last so long into the night that even with Boost, it can be really hard to catch up.
Yeah, and if you think that you've got someone, or you're using the system yourself, and you think, I'm not sure if my carbohydrate counting skills are perhaps as good as I thought they were, or you've got someone that you want to kind of point in that direction, there's a really good refresher on the training portal of the website, just a kind of half an hour module on refreshing carbohydrate counting skills to direct people to as well.
And then maybe reminding people as well that they will, even if their carb counting was spot on and the carb ratios were absolutely correct, there still often needs to be an adjustment, isn't it? We often find we still have to tweak them a little bit up or down at the initial start of closed loop.
Yeah, that's right. I think quite often, if you've got someone that transfers to closed loop that's been on a pump for a long time and is kind of quite confident in their carb ratios pre-closed loop on an insulin pump, actually we often find that when you start closed loop, the carb ratios still need to be adjusted. It's not necessarily that their overall insulin requirements have kind of increased. It's more that the distribution is different when you're using a closed loop system. So it's definitely important to reduce to review that insulin carb ratio, and you can see straight away, with the first meal on the first day if it's looking like it's not working out. So what we'd encourage people to do are, look at days where they're, pretty confident their carb counting has been as accurate as possible, and then review the glucose profile. We've got some slides in a minute that will cover it, but at all times of day, at all meal times, and see if anything needs adjusting. If you're getting kind of persistent post-meal hypos, it might be that the carb ratio is too strong, too aggressive. If it's there's a kind of sharper rise, you're going above that 7.8 level, and the system's having to really ramp up to deliver lots of extra insulin to support the bolus after a meal, then maybe the carb ratio is a little bit too weak, needs to be made a little bit more aggressive. And just to clarify, you change all the carb ratios on the pump itself. The app reads the carb ratios from the pump. There's no settings that you change on the app. And again, in the same way as the other slides, if you just want a point of reference, this is a slide that just covers where you go to change those carb ratios. And this highlights really nicely this slide where the insulin carb ratio is not aggressive enough. So you can see at breakfast time there, sort of about 7:30, where the little green triangle is, there's a meal bolus has gone in. You can see the amount in the slide in the part below in the red circle, 2.6 units. And you can see the glucose level has raised well above target. And you can also see the work that the algorithm's having to do in the background to try and get on top of that glucose level. And this can often happen. You can see the system can ramp up to deliver the extra, but because there's then the mismatch between the insulin absorption and the absorption of carbs, you often then find you get this dip later where the system then, you know, as the drop starts, it's backing off to nothing. This person's popped ease off on, which has probably made very little difference because the system wasn't delivering anything in any case. And you know, skimmed there. And if you get those kind of periods of time where the system's had to give a lot and then back off a lot, you end up with this very much more sort of up and down roller coaster sort of pattern. So in that situation, you'd be looking to see, is that a pattern? Does that happen? Is that happened a few mornings? Do I need to be more aggressive with that carb ratio? Or actually, is it the type and the quality of carbohydrate and the amount of carbohydrate that's being taken that needs to be considered as well? It might be a mixture of all those things. The next slide is the opposite problem. You've got a bolus that's gone in there again, just to kind of about just before 9 o'clock in the morning with a little green triangle, and you can see the insulin bolus there of 5.7 units. And you can see then after that bolus has gone in, the system has backed off to nothing straight away. It was already kind of on the lower side and dropping, and it knows it needs to not give any more insulin. It's not clear whether the person may have had to get in with some additional carbohydrate to get that rise. I'm thinking probably yes, by the sort of rate after it goes kind of about 11 o'clock with a little dip. You can see again, this is someone who's popped ease off on. Now that's not made any difference at all because the system has already backed off to nothing. And one of the things that's really useful to mention on this slide is you can see, Charlotte can point with the arrow just after 10 and then just around 12, there's too little amounts of insulin given, and people often get in touch and say, I don't understand why closed loop was delivering me extra insulin when actually I was already below target. But what those little pulses are is the system has to give a minimum of a pulse of 0.04 units every hour to keep the line patent. So it's a really, really tight, it looks kind of probably more than it actually is on there. And people get concerned sometimes that it's giving insulin when you're already on the low side, but that's the sort of absolute bare minimum the pump has to deliver in an hour. So in this situation, because the bolus is too aggressive, again, you wouldn't be basing it on just one reading. Probably you're going to want to see, did we count the carbs wrong there? Was there something else going on? But if you're seeing that pattern a lot, what you want to do is be thinking the carb ratio is probably a bit too aggressive and going up 1 or 2 grams. The sort of dream is the in between. The first slide you saw where the system had ramped up a lot to deliver lots of extra insulin to try and help. This screen grab, you're seeing it's kind of had to back off to nothing. You kind of want a happy medium where the bolus goes in, the system trickles a little bit of insulin in to help out, but that's as far as it goes, and it helps really keep everything flattened within that 7.8 higher end of the target range. So one of the other things that's super important is the timing of the boluses. With any closed loop system, post-meal bolusing is something that can particularly cause problems because the system started to ramp up for the meal that's the carbs that are coming through, then the bolus that goes in late, and then the upshot is almost is the kind of like giving a sort of double correction, if you like. The system's corrected and then you've put the actual insulin bolus in on top, and that risks the hypo, which this slide shows really nicely. But I think, Helen, do you want to just talk a little bit about your thoughts around pre-meal bolusing?
Yeah, I mean, I think probably after getting accurate carb counting and making sure the insulin carbohydrate ratio is correct, this is probably the next single most important factor, isn't it? The timing of the prandial insulin bolus in relation to eating. And certainly outside of closed loop, most of us are now used to giving insulin 10-15 minutes in advance of eating in early pregnancy, and then increasing to maybe 20-30, even 30 to 45 minutes as pregnancy goes on. And certainly what we seem to be seeing in closed loop is that we probably don't need to pre-bolus any much more than 10 to 15 minutes. I think because there's still some insulin on board, and because the system is auto correcting all the time, we don't seem to need such a long gap between injecting and eating as we do off the system. Are you seeing that as well, Sarah?
Yeah, I think we have been, and certainly initially when we were recommending kind of people, you know, second trimester earlier again, and third trimester even earlier, sort of up to sort of you know, 40-45 minutes before, we were seeing these dips pre-meal, which then meant that when the glucose was starting to rise, the system had actually been backing off for quite a long time before, and that then seemed to make the high higher. You get this more kind of up and down pattern, whereas if the system's kind of constantly delivering something, never backing off to nothing, then everything's much smoother, and you seem to avoid, again, topping out that sort of above that 7.8 higher end of the target. So yeah, I think it just helps to stop the kind of on off of the system if it's not done too far in advance.
Yeah, agreed.
And then one of the other really important things, again, it's just basics of pump therapy. So infusion set changes, making sure sets are changed every 2 to 3 days, probably towards the end of pregnancy, more kind of the 2 days is needed. And it's really important for the learning of the algorithm. So if you've got kind of poor absorption on the 3rd day, then that's obviously going to affect kind of how it's learning as it goes on. So it's definitely better to make sure. And there's now an alarm on the alerts section of the app that you can set to remind you to change every 2 days. We also just, one of the things in any type of closed loop system, if you are disconnected from the system or the pump for more than 15 minutes, then it's better if you suspend the pump. At the moment, you have to do this on the pump itself. We're hoping actually that will be an update in the app, so you'll be able to suspend the pump from the app, but at the moment you do have to do it on the pump. So yeah, if you're disconnected from the system for more than 15 minutes because you're having a bath or going for a swim, then suspend it, because the algorithm it's basing its learning on and its sort of function on insulin, it obviously thinks that's gone into the person rather than, you know, has just been kind of dripping away somewhere while you're in the bath or having a swim. And an obvious thing really, but trying to keep closed loop running as for the highest percentage of time possible by making sure you stay within 6 meters of the phone, keeping the phone on you to stop those disconnects. And another really important thing is just the differences potentially in management of hypoglycemia. So what we see with closed loop systems is that you often need far less rapid acting carbohydrate to sort out kind of a potential low or even an actual episode of hypoglycemia if it gets to that point. So I think it's thinking about the alarm settings, the low alarm settings, as being your kind of warning point, wherever that is suitable for you individually or the person individually, that low alarm is the point where they turn the phone on its side, look at the landscape of what the system's been doing and make a decision. What's been going on in the last half an hour, 45 minutes? If they've been kind of gently on the drop and they look and the system hasn't been giving any insulin for the last kind of, you know, half an hour, 45 minutes, that, you know, you might take a punt that actually, I think actually it's going to be fine, it's going to skim, or depending, you know, potentially instead of an arrow on the angle, you've got a down arrow at the point your alarm glows. You might think, do you know, I think I need to give the system a helping hand here, and even have like 4 grams of carbohydrate, 1 jelly baby, one supplement, whatever it is you want to go, just to help it skim, and that can be enough. And what you find is if you overdo the hypo treatment, is because quite often the system will have been desperately trying to avoid the dip and not delivering any insulin for quite a long time in advance. If a bigger amount of carbs goes in, then you get the, you get the opposite from desired effect and get a huge swing back up the other way.
And Sarah, we found that especially useful overnight. So I think that's been one of the biggest differences women have reported back, is that they can manage the overnight hypos when you know there's no bolus or prandial insulin around, with very, very teeny tiny amounts of carbohydrate.
Yeah, exactly. So so yeah, you're using those alarms and you're looking at the information that you've got of what's been delivered by auto-mode to make a decision based, alongside your direction arrows of how much you think you need to go. It's quite a good arrow on the slant, 4 grams, straight down arrows, you might need 8 grams as a starting point, and then work from there. And as we said earlier, if you're having a run of lows, especially at the beginning when closed loop's kind of getting to grips and learning, consider just raising that personal glucose target to 5.8 for a few days, and then you can nudge it back down again when things have settled down a bit. So we're just going to go through reviewing some data that Charlotte and Helen will take you through.
So this is one of the best bits, I think. It's one of the best bits of our job, is actually being able to really visualize in real time, accurate and easy to interpret clinical data. This is one just of this is a recent couple of weeks in someone in their third trimester. So you can see the very large prandial insulin doses. And, this is really what we expect by the end of pregnancy. 70% of the insulin is going to be given in terms of boluses. And the algorithm might only have to give 25 or 30%. This is what we're aiming for, to get as many women as possible to that 70-75% time in range, the mean glucose of 6.3, with the absolute bare minimum of lows. And you can see this person was having a few of those overnight lows that Sarah was just talking about. And I think, again, it took some time to just reiterate the message that 4, 5, 6 grams of carb would be absolutely fine. You don't need to treat those with large amounts of fast-acting carbohydrate. And here it's just showing that, reviewing, when women come back into clinic, it's really helpful to have a look at the DIASCEND in terms of using that function that says comparison and then day by day, because then you can see exactly what's happening, where they're using boost, where they're using ease off, and how much insulin is being delivered, both by the person with the boluses, and then also you can see clearly what the algorithm is doing in between times. And people are varied about how often they want to receive the CamAPS reports. I mean, I certainly clinically, especially in the midst of COVID, find it really helpful to get this day-by-day report. This is just one that we've pulled off over the last week. And, you can see, okay, overall, women are doing largely well. This includes a few women who are postnatal, so the average might be running for them a little bit higher. This is one of our postnatal women. But we were able to look at this and say, oh, this is highlighted in red. There's a problem. Someone's only 6% time in range when she normally might be 60, 65, 70. And actually it was someone who'd run out of supplies, who'd run out of catheters and didn't want to bother anyone on the weekend. So, you can just be alerted very, very quickly and hopefully prevent an admission or a DKA. By keeping a bit of an eye on those. Now, they don't replace the detailed look you get from the DIASCEND data, but they're a great and quick snapshot of everyone is fine or someone actually needs a bit of help and support.
Mm-hmm. And Helen, these are just for healthcare professionals and just for the patients in their clinic. So you can't see anyone else who's outside your clinic or anything. Just and if you're a user of the system, you don't have access to this, but hugely helpful, I think, in seeing a great number of people all in, as you say, a snapshot for you just to troubleshoot. And
that's just the same again, showing that bit more legible on the larger screen. Now, certainly the qualitative feedback we had from women during the pilot studies was one of the things they found most useful about the system was being able to use it through delivery, both labor and delivery and cesarean sections. And also women who are admitted to hospital, as they often are in late pregnancy, for antenatal steroids. So some of the things to think about, well, certainly in relation to the delivery, is making sure that the pump cannula is inserted well out of the way of the where they're likely to have the cesarean incision. Now, normally by late pregnancy, women are moving their cannulas round to the flank and off the abdomen anyhow. Occasionally you will find that if there's an unplanned cesarean, just the catheter is in the way. So I think it's good practice to move it around from 28, 30 weeks around to the flank. Now, what we can do in terms of setting up the system to be ready to cope with this, with the dramatic changes that are required after the baby's delivered, is getting the carb ratios ready from before. What we usually will do is, if women are fasting, many women now, of course, are delivering by cesarean, so they'll be nil by mouth the night before. So then we might raise the personal glucose target up to 5.8 from the midnight before. Remember then to change the targets. They're not aiming for 3.5 to 7.8, but 3.9 to 10. And I'll often take the personal glucose target, 5.8, even 6 for the first day or two in hospital, just to keep women safe from the concerns about severe hypo. And I think we have an example. Yes, this is from one of our study participants who delivered yesterday, and this Monday, the 18th of January, was her last day in the pregnancy. So you can see the really large prandial boluses, 182 units of insulin that she's giving. We, on the night before coming in, say definitely, take care with the evening meal. This is not the night to have very high glucose levels. Give a good bolus, but then raise the personal glucose target to 5.8 from midnight. And then I think on the next slide we have that. So nice and stable glucose targets, glucose levels through the night. You can see the system's working hard to do that. And then she delivered yesterday by a planned cesarean, 37 plus 5. And you can see, almost tell the timing. So her cesarean section was at 8 a.m. yesterday morning. Usually you will see a little bit of a rise in glucose levels in the immediate operative phase, and then nicely managed to avoid any hypos, and then stayed on the system throughout. So not needing a sliding scale, not having to, just keeping mobility and being able to move around, go and see their babies if they are in NICU. This baby thankfully was healthy, at normal weight, normal blood sugars, and was able to stay with his mum. So she was able to get breastfeeding initiated. And one of the real problems is if women are attached to sliding scale, it's very difficult, especially if the baby is in the neonatal intensive care, to get breastfeeding started. So I think this ability to keep safe in hospital and reduce the risk of hypos, but also for mums to be able to just focus on their babies and not have to worry quite so much about the glucose levels, has been a real, it's been one of the best bits of it, actually. And this is what in fact, one of our trial participants made her own little alert that she takes into hospital to show the staff, saying, please do not remove my sensor. Please don't pull my pump off. Now, it still does happen. But ask me about this closed loop system and I'll tell you. We give them written information for the hospital record as well as for the women themselves to say it's safe to use it during steroids through labour and delivery in theatre. We find the theatre nurses in particular very aggressive at sometimes wanting to get pumps and sensors off women. So it's really important that we just say, don't remove my sensor, don't remove my pump without my consent. It's not a problem, of course, to suspend the pump if the glucose levels are lower than 6 going into the cesarean. Then you might, of course, suspend it for 30 to 40 minutes or even up to an hour, but don't take it off.
Brilliant. So hopefully over the last sort of 30 minutes or so, we've covered what we set out to do, so a bit about an overview, the specific targets of pregnancy, and really how to sort of utilise the closed loop system for women throughout their pregnancy, really highlighting the importance of sort of getting the basics right, and how you can keep an eye on things throughout the pregnancy using this sort of different data platforms, so the DIASEND one and also the clinic report where appropriate, and also some advice about delivery and post-delivery. So I think, Candice, we might be hopefully moving on to maybe some questions if we've got some time.
No, absolutely. We've got a few questions and I'm sure there'll be some more coming. But the first question is around the use of Boost. Helen, you mentioned using Boost overnight, sort of after the evening meal. And there's a question around, if you've got Boost on, the system generally doesn't learn in the same way as it would learn when Boost wasn't on. And what's your sort of comment on, is it worth to miss out on the learning and use Boost, or you know, excuse me, how do
I tend to think of it that most of what happens after meals is really depending on the bolus dose, more so than the basal insulin. So I think actually, of course, do as Sarah has suggested, get the carb, make sure the carb counting is as accurate as possible, get the carb ratios as optimal as possible, get the timing of the bolus right. But even amongst women who do all that, in my experience, the vast majority still need to boost for 2 to 4 hours. Not so much necessarily in early pregnancy, by which I mean kind of the first 8 weeks, but almost universally from 10, 12 weeks onwards. Most women I find are using Boost at least once or twice a day. Actually, I don't know if Charlotte, if you've got any data on that yet. We'll have the data coming on the use of Boost, but I think it's almost ubiquitous. And I think it's much better because every bit of extra fetal exposure to maternal glucose probably isn't good. So I say boost away, boost to your heart's content, as much as you like, as often as you like, and for as long as you like, because you really don't need to worry about hypos with Boost.
Thank you. There was a question about using ease off at delivery. Do you think that's sort of something that you should inform women to put on, or do you leave the system to work?
Yeah. I think, so what I suggest is kind of treating delivery a little bit like exercise. So if the glucose levels are less than 6, either putting on ease off, raising the personal glucose target, or just suspending. For cesarean, it usually only takes about 40-45 minutes from start to finish. So it's not a problem to suspend insulin for that. So we've tended not to use ease off quite so much. For women, though, who are having an induction, then at various times it can be useful to use ease off. And I kind of, we would normally say keep the personal glucose target at about 5.8 and do ease off. I think ease off can be even more useful maybe after delivery, but don't tend to use it that much during.
And would you use it around sort of breastfeeding initiation and sort of that kind of stage?
Yeah, absolutely. I think that's where it comes into its own, isn't it? In the postpartum period, because despite having reduced the carb ratios and rising the target, the Boost again, if glucose levels are 6 or below, heading into a feed, then stick ease off on for 2 to 4 hours.
That's really helpful. So there's a question about sort of, do you have any protocols of when you'd move to sort of an insulin infusion away from the closed loop? Is there sort of flags or certain cutoff points that you use?
I mean, I personally don't think there's any insulin infusion system around that is going to be able to safely deliver the insulin to the same degree of effectiveness as the closed loop. So only in the setting where maybe maternal glucoses are above 10 or 12, or there's someone who really is not able to self-manage, then it may be in those circumstances. We've not had to do that yet. We had one circumstance actually where the theatre staff a woman came in for a spontaneous rupture of membranes, and the pump was just in the wrong place, so it had to be removed. And she was on a sliding scale for I think 3 or 4 hours. But actually, most women have safely. We've not had to, because we don't see those out of range readings that might require a sliding scale in women who are using the system. It just hasn't happened.
And what do you do around steroids? Do you just use Boost and adjust the ratios? Or?
That's right. So so we use So the first thing we do with steroids is make sure the personal glucose target is down. Usually it is, because the steroids are coming in later on in pregnancy, but make sure it's kind of in the 4.5 to 5 range. And then, yes, just, yeah, say boost your heart's content. And, you know, important to note that actually you still won't get perfect glucose levels, even with closed loop after steroids. But I think that you probably still get much safer and better levels than you would using a sliding scale. So still expect them to be a little bit above the target for maybe for 24, 48 hours in most women, unless there's something else going on. And actually we're slightly worried more for the women whose blood sugars don't rise after steroids. And we've seen a couple of women like that who with nephropathy or preeclampsia, and you give them steroids and they're not needing to use boost, and that maybe rings a few alarm bells.
Okay, I have a question about sort of more, you know, acceptability of a closed loop system, because obviously there's, you know, there's the phone and the pump and the Dexcom, all of it together, and we've seen data of quality of life and reduced burden in other areas. What's your feeling around pregnancy and pregnancy women managing the system from more of an emotional, you know, well-being side of things and quality of life?
I mean, I would say manage the expectations. You know, it's really hard having type 1 diabetes. It's like double the effort if you're pregnant. And then, you know, when you think of how much focus and time and effort women have to put into doing all of the normal things of just how much, you know, making sure that they're counting the carbs accurately, thinking about the timing of the boluses, and then doing all of this on top of it. So I would suggest that it takes a good 2 to 4 weeks for it to become the new normal. And I tell women to expect to have to work a little bit harder in the first 2 to 4 weeks, especially if they're new to pump. Thereafter, certainly anecdotally, I think the experiences are overwhelmingly good. And certainly our person who was delivered yesterday said it's the first time she's felt like she's had a normal, healthy pregnancy. So that's what we're aiming for.
That sounds amazing.
And we're doing some detailed qualitative research from a selected number of closed loop users in the ADAP pregnancy study. And then we'll be interviewing a range of healthcare professionals as well. So we get much more information, I think, in the future about how women are experiencing it in their day-to-day lives.
There's a question about for IOL, at what point do you raise the target? So
for IOL being induction of labor, I'm guessing this is in relation to the personal glucose target. Yeah, I mean, it's an excellent question. We tend to kind of keep an eye on it. So I tend to keep a watch on it through Diasend. And if it looks like the glucose levels are just on a real downward trend, and especially if they're going down and the system has not been giving much insulin, then I would look to raise the target a little bit.
And then if somebody is using the pump during delivery, I mean, the closed loop system in delivery, because it's a hybrid, you know, if people are, you know, do people need to bolus while they're in delivery? Is it one extra thing, or is the pump able to actually cope with everything that's going on if there's an extended delivery or something like that going on?
You know, the reality, of course, is that about 75% of our women with type 1 are delivered via cesarean, so either an elective planned one, which is quite easy, or an emergency one. So it's only about 25% of women. In the first day or two of the induction, where before proper labour is established, then yes, they're eating and drinking as normally, and they just need to do everything. They still need to bolus. Yeah, and all of those things that Sarah has highlighted, be still trying to be accurate. Often women will bring their own meals in with them because the hospital food no one was going to reach the pregnancy glucose targets with hospital food. So a lot of women will bring their own food in for their induction, take things that they know they're able to match insulin to. And just, yeah, it's the last, you can still continue to aim for the tight pregnancy targets and bolusing 10-15 minutes in advance.
Thank you. Another question, when you're tightening the target, how quickly or by what increments do you tighten by?
I mean, what we usually do, so Sarah and I would normally start off at 5.5, and then I usually do it by 0.5. So as soon as you're less worried, someone's got good hypo awareness and not a high risk of severe hypos, I would generally be moving to 5.0 by 10 to 12 weeks, in most cases, but always by 14 to 16 weeks in all cases. I think that we have more and more data now to suggest that the earlier you reach the pregnancy glucose targets, the better the outcomes for the mother and the baby. And we know from a lot of other work in pregnancy that often there's little or no improvement in maternal glucose levels between 10, 12 weeks and 28 to 30. So I think over this last few years, we've been much, much more focused on optimizing glucose levels through the second trimester. So as soon as it's safe to do so, I would say take it from 5.5 down to 5.0. And then as Sarah was suggesting, sometimes we still see some women who run a little bit high after the evening meal. So in that circumstance, we might set a target of 4.5. I find it's often good to do that from about 8 p.m. through till midnight. So then they're going into the evening well. And then often actually you'll just find that they continue that the whole way through the night, and then raising it again. So one of the big advantages on the current system is you can set a time range for the target. So where you're not worried. So the person I just showed you who was using high doses of prandial insulin, she would have had a glucose target of 4.5 from about 8 p.m. through to 8 a.m. and then 5.0 through the wakening hours.
That's very helpful. So when these women are using all this insulin and getting tighter control, what's happening with their weight? Is there any evidence that they put on more or?
Yeah, well, I mean, it's early days, of course, and we've not had a whole lot of women using this system, but anecdotally, and I think we're seeing far less gestational weight gain than previously. And I think a lot of that is down to the hypo management. So as Sarah said, not having to treat overnight hypos with 10, 15, 20 grams of carb, but just treating with 4 to 5. So I think the likely we'll know the answer to that when we finish this study. But anecdotally, in the early stages, many of the women who are finding that they've gained less weight through their pregnancies compared to previous pregnancies.
That's really good news. Are there any other questions? I think I've gone through them and I haven't missed anybody's questions, but any last minute questions or anybody want to pick anybody's brain in the panel?
I mean, the only other thing I would say to people is that, you know, it does take, we say to women that it takes 2 to 4 weeks. It probably also takes, I find that I do need to look at it fairly closely over the first 1 to 2 weeks. And often, as in many things in clinical management, you know, there are a few different options of what to do. So I will often find that I just want another pair of eyes on it. And I'll say to Sarah, look, can you just have a look? Or to Charlotte, someone else have a look, what would you do? And I would just say to people, you know, we're around, it's still early days of using closed loop in pregnancy, more than happy to always look at the profiles and give an opinion. We won't always have the right answers, but we'll mostly have an opinion and really happy to help, especially in those first. I think if we can get women off to a good start, then actually the rest of pregnancy is so easy. So yeah, for anyone using it, like feel free to ask us. We're always happy to have a look at a DIASCEND profile.
No, thank you, Helen. I think that's a great offer, and you're absolutely right. What you may see, somebody else may miss, and vice versa. And it's really great to have a community to pick each other's brains. So thank you for that offer.
So sometimes I'll want to change the carb ratio, and I'll look at Sarah, and she'll say, "No, just sit tight for a day or two." And you know, and usually she's right.
Annoyingly so. Oh no, well, thank you very much. I'm getting a lot of comments saying thank you very much. That was a great session. So I really appreciate your pearls of wisdom, Helen and Charlotte and Sarah. Thank you for your time. This session will be uploaded to the training platform, the CamAPS online training that you can access via camdiab.com, and it will be there hopefully in the next 24 hours. So thank you very much everyone for your time. Have a great evening and keep safe. Thank you and goodbye.